Hi, everyone. My name is Dayla Miller, and I am the Program Director of Total Health Conferencing. I'm so excited to welcome you to our third annual Best of Breast Conference. Although we're virtual this year, we're proud to be able to provide a program set completely in a multidisciplinary tumor-borne environment. Our experts have engineered breast cancer cases beginning with high-risk characteristics and walk us through survivorship, all while incorporating data from the major annual meetings. We encourage you to engage in the chat and ask questions to our panelists throughout the day. I'd also like to take a moment to thank our exhibitors because without them, this meeting would not be able to happen. Please visit the exhibit hall and interact with the reps as they're readily available all day. Thank you for joining us, and we're looking forward to a fun day of learning.
All right, so thank you all for joining us for a session on genetic and genomic testing. I'm Dr. Jennifer Klemp. I'm a professor of medicine in the Division of Medical Oncology at the University of Kansas Cancer Center, and I'm our Director of Cancer Survivorship, and my practice is cancer genetics. And today we have an amazing panel, which not only are they distinguished and experts in their field, I think we have a great discussion to really highlight some of the important issues surrounding precision medicine. So I'd like to start by introducing each of our panelists and let them tell you a little bit about themselves. Dr. Chung.
Hi, I'm Wendy Chung. I'm the Director of Clinical Genetics at Columbia University and the Precision Medicine Resource Director in our Irving Institute.
And Dr. Meisel.
Hi, I'm Jane Meisel. I'm one of the medical oncologists at Winship Cancer Institute at Emory University. I've been here for about 6 years and have a special interest in breast and ovarian cancers. And so I've done a lot of work with BRCA1, BRCA2 associated cancers, and definitely am excited for this discussion today.
Great. And Dr. Yepes.
Hi, I'm Monica Yepes. I'm the Division Director of Breast Imaging at the University of Miami at the Sylvester Comprehensive Cancer Center and Jackson Memorial Hospital. We have a high-risk group with breast cancer, and genetics has become a very important part of our practice.
Great. So as you can hear, we have a very distinguished panel, and we are excited to kind of dive in and talk a little bit about sort of just a quick review of genetics and genomics. The changes in nomenclature, which I think has been sort of interesting because our patients sort of have one set of terms and we use a whole lot of terms. How do we optimize testing and really bring that to a point of service care model? How do we manage that risk, and how does it impact our treatment and shared decision-making with our patients? And how does that information incorporate into our patients and their families through cascade testing? So we kind of have a nice review of quite a few things. I kind of stole this from San Antonio this year, where there was a nice sort of tried to be sort of a yes and no discussion about, do we think every patient should have genetic testing or germline testing? And this was Dr. Robson and Dr. Domachek had sort of the pro and the con of this. But I'd like to kind of go around and ask our panel that, since I think there are pros and cons to testing, and I'd like to sort of right size us as we get into this discussion today. So we'll start with Dr. Chung. What do you think? Should every patient with breast cancer undergo germline testing?
So I'm going to say a little bit different. I'd say every patient should be offered genetic testing. So I won't necessarily say they have to have it, but I do think everyone should be offered the testing.
Great. Dr. Meisel?
I would agree with that. I think we'll get into some more of the nuances of this. Like, for example, every patient with metastatic breast cancer, I think it becomes a little bit easier to say yes, just because of some of the impacts now that a positive genetic mutation can have on treatment options. But I do think it's, different people have different opinions about how much information they want about themselves. And, for a lot of, very early stage breast cancer patients, which fortunately is still the majority of breast cancer nationwide, they may not necessarily need it in terms of impacting their care. So I do think it's, one of those things where everyone should have the opportunity ideally. But I don't know that everyone should be, deeply encouraged to do it if they don't necessarily have the inclination to do so after hearing about all the options.
Great. And Dr. Yepes?
Well, I think we kind of hold back a little more. I think we have to take into consideration, obviously, stage of cancer, patient age, and family. Not only the family history, but whether the patient actually has descendants. Do they have children? Oftentimes we have patients who have no children, and a 70-year-old with a DCIS who has no children. I don't know how much more information that's really going to offer. So I think we do still need to put it into context, but I would say the vast majority of patients should be offered it at least.
And I like the way you worded that, because there's sort of that risk stratification within risk stratification sort of implication. So we will get into that discussion because I think it's not a yes or no sort of scenario, and it does have some nuances that are worth further discussing. So we're going to turn it over to Dr. Chung, who's going to give us a quick review on some basics of genetics and genomics.
Okay, so this nomenclature, as Jennifer was saying, has changed a bit over time, and I'm going to be kind of a strict geneticist in terms of thinking about this. So I think the bottom line is that most breast cancers, we don't know why they happen from a genetic point of view, and so we tend to use this word sporadic, which is that, to be honest, we're just kind of ignorant at this point. And the old nomenclature we used was hereditary, which used to mean for us, I think paradigmatically, we thought of those as BRCA1 or BRCA2, in other words, monogenic factors that were really powerful. We use the term penetrant, but genes that had a strong impact in terms of increasing the relative risk in a significant way, oftentimes 8 or 10-fold what the population risk was. Then we would put into this bucket of familial those individuals who had a family history but didn't have an identifiable single genetic factor. I'd say in reality, it's more complicated than that, but that's at least the old paradigm we used to use. And I think this sort of boundaries, you see two different shades within hereditary. And that's because in part, we started realizing that there are monogenic factors or single gene factors. But as you see, as we go through this, they don't all have this relative risk that's 8 to 10-fold. Some of them might be 2 to 3-fold, but they're kind of wimpier genes. And we're not going to talk too much about it, but we're even starting to get into the space of polygenic risk scores, which are things that are like aggregates of dozens to hundreds of genetic variants, each of which have very small effect size, but when you wrap them up all together, may have a larger effect size. So next slide. So the next part of things that gets a little bit confusing is there's genetics and there's genetics. And what I mean by that is the genetics that you're born with, and they're the genetics that change over your lifetime. So the genetics that you're born with, we call the germline, because those came through the egg and the sperm. And then we think about somatic mutations, which are things that happen over the lifetime, over the life course. And of course, your genome from a cancer point of view is not stable. It's constantly changing, and the older we get, the more it changes. And that's why we see more cancer in older people than we see in younger people. The thing that you're also going to hear us talk about a little bit today is sometimes within the same gene, some individuals are born with a change in one copy of the gene, and then they acquire a somatic mutation in the second copy of the gene. And so even within one gene, so to speak, you may have changes. Next slide. So as we're talking about this in terms of cancer testing, the other thing that gets a little bit confusing is what we're actually testing. So when we think about the biological specimen that we use, where do we get that sample and what are we actually zoning in on as we're doing that? So for germline testing, as an example, you can take a lot of different sources. You could take a blood sample, you could take a saliva sample or a cheek swab. Lots of parts of your body look the same when it comes to that. But when you're talking about the somatic testing, you really got to get the tumor itself, because that's what we're interested in terms of what's changed. And that's what we're targeting with some of our cancer treatments specifically. And in some cases, we actually do both of them. So we do a tumor normal paired sample to be able to understand what you were born with and then what changed in terms of those somatic changes. Within this, there are some tests that we call genomic, and genomic to us means really looking at the genome as a whole. So we're doing a comprehensive way of looking at that. It can be at the RNA or the DNA level as we're doing that. And then sometimes we do more focused, targeted testing, and we usually do that when we're talking about germline testing for a specific panel of genes.
And Dr. Chung, you brought up this term tumor normal, which we talk a lot about in our molecular tumor boards now. And so let's say you had a breast cancer patient that was being looked at for a clinical trial, and they had one of these large somatic panels, maybe through a foundation or a Caris or a Tempus or a lab in-house. And you did find a mutation, whether it's a BRCA1 or a PALB2. is it standard? Because I know that in academic practices, we would often reflex that patient, or should they be reflexed? Or what would you really recommend as people are tackling, how they get this information? And does one mutation on each of these tests signify that there will be a mutation on the other type of test?
Great question. So different institutions, and I tend to see that their institutional decisions will do, when they're doing the cancer, directly looking at the tumor, that is, some of them will do, as you were saying, Jennifer, in terms of tumor normal. So that is, they've got either normal tissue or a blood sample paired with the tumor itself, and therefore they can very easily distinguish somatic mutations from those germline mutations. Other institutions, and I'll say myself, ours is one of them, will do tumor sequencing, but not necessarily paranormal with it. And so when you see a change in one of those genes, you're not always sure, was it a somatic change just within the tumor, or was it a germline variant? And we'll get into some of the implications of these germline variants, but they are different. They're certainly different, as Monica was saying, in terms of families, so the implications for the next generation, but they can also be different in terms of the implications for either other tumors within your patient or how you would treat your patient.
Thank you.
So in doing this, we use this information for several different ways. So we talked about this idea of individualized or personalized medicine. We're doing it because and this is, I think, probably no news to anyone here, but not all breast cancers are the same, right? They're going to have a difference in prognosis, a difference in terms of response to treatment, differences potentially in terms of other associated cancers. So we're trying to do this all in terms of getting both prognostic information as well as trying to predict what the response to treatment would be. And over time, we hope we get better and better to know that we don't over-treat people. So as you're seeing in the lower right, and I know many of you are used to doing a mammoprint or an Oncotype DX test, trying to get some sense of who really needs to have, for instance, systemic chemotherapy and who doesn't, as well as we get into this, we try and sometimes, if you will, repurpose drugs, but think about drugs that might be based on a molecular signature useful to use in one type of tumor for one type of patient.
Great.
So I'm going to try and make some of the gobbledygook that's on your test reports a little bit easier to understand. So geneticists like myself use really, I think, sometimes overly technical terms, but we do it because there's been this consensus within the American College of Medical Genetics and AMP, the American Molecular Pathologist. So any particular DNA variant, we classify in one of 5 ways. And you can see they're clustered. And basically the way I think most physicians are used to thinking about it, or it's either positive, negative, or what I call genetic purgatory, that question mark in the middle. So positive in our speak is that it's either pathogenic, so the variant is, we think, disease associated. For that, we usually think we're close to 100% certain of that. So we tend in this day and age not to reclassify those. Likely pathogenic for us, just to let you know, means that we're about 90% certain that that particular variant is actually disease causing or disease associated. It's not 100%. The other ones on the other side, benign and likely benign, are very likely to not be disease associated, at least in the way we think about it today. And the ones in the middle, as I said, are variants of uncertain significance. Amongst those variants of uncertain significance, we're more likely to see those in individuals who are not of European ancestry, so any place else around the world. And 90% of the time, those will be eventually reclassified to likely benign or benign. So most of those that are in purgatory eventually get reclassified to not be anything worth considering or worth worrying about. As a result of that, most of us do not act clinically on variants of uncertain significance because eventually they'll go away, so to speak. But for certain individuals, as we get into some of the genes, the clinical features really match what that gene is, then you might consider whether or not you would actually eventually reclassify that upward into likely pathogenic.
And so I think one of the reasons we wanted to have this nomenclature sort of on as part of this discussion is because older reports would have had sort of positive, negative, and so forth, whereas new reports now have transitioned, and patients are sort of having struggles with that. So there's been quite a bit of momentum from professional organizations and so forth to help sort of educate patients. But I see it in notes, like it's sort of across the board, even amongst colleagues. So when you're sort of educating and recalibrating, are you making sure that people use sort of the ACMG criteria, or because clinically we're still working on positive, negative, or uncertain, like how do you handle that sort of in your discussions with either colleagues or patients?
So as you're saying, Jennifer, I think the sort of common communications are positive, negative, and uncertain, to be really simple. I also communicate with a lot of, very technical people. And so we'll use the technical speak, and we'll go one level further, which is not just to say that it's likely pathogenic, but what are the actual criteria that were met that made the classification of that. But I get down in the weeds of that. I'd say the easiest way to think about this from a patient point of view is positive or negative, but I will warn you that sometimes patients misunderstand that information in the sense that they say positive, oh, this is a good result. This is a positive thing for my prognosis, or negative, this is really bad, right? That's a bad prognostic factor. So just be careful and explain fully what you mean by that if you say positive or negative to a patient.
And I think you bring up a good opportunity for sort of right sizing with the patient by maybe even using a little reflective listening to hear what did that patient hear from that dialogue, but really important and is why we focus so much on this whole term about nomenclature now, as do a lot of the professional organizations. So really has come to the forefront.
Okay, so within this, many of us are now used to doing gene panels. So if we'd been given this talk a year or 10 years ago, for instance, we probably would have been talking about BRCA1 and BRCA2, because 10 years ago, that's primarily what we were doing. Since then, we've expanded in terms of the number of genes we look at, I call it baby bear, mama bear, papa bear, but there are certainly different size panels that one can use, in part based on your patient, their age of diagnosis, their cancers, their family history, all of those things into consideration, you can make a decision. But here are really the genes that are most commonly for breast specifically included within the panels that are most commonly used clinically. Some of them are more or less frequent, but this is really most of the news you can use, is the way I phrase it to patients.
I like that. I'm going to steal some of those phrases you just said. I like the mama bear, papa bear. So from Dr. Chung, we've just learned some new little acronyms. And I think that this fits nicely really into that shared decision making. And so as we're talking to patients and as we're really trying to frame it in a language that's important to them, and as we've kind of already heard, this does play into part based on patient preferences and what they want to know and how much they want to know. And so I'd like to hear from the rest of the panel too, as we're thinking about incorporating sort of this higher level of information into most of our patient discussions. How do you address how much information is appropriate and put this into that shared decision-making model?
Absolutely. I mean, I think this is something we address really every day with our breast cancer patients, and certainly when we're talking about genetic testing. I think for every patient, there's sort of the question of, how likely is it that you would have a mutation in a certain gene, and also how much do you want to know? I think, for many patients, it can be a relatively easier decision to say that they want to do BRCA1 and BRCA2 testing, because those are genes where, as we'll talk about, we can give people very clear guidance based on lots of data about how that should impact their breast cancer care and their future risks. But then there's some other genes that we're starting to learn more about, but that we don't necessarily have definitive guidelines for patients right now about exactly how much risk it adds and exactly how it should inform their medical decision making. So for some patients who are more anxiety prone, knowing more could potentially cause more anxiety and maybe not help them as much in the long run, just because of who they are. I'll give a little bit of a quick personal anecdote in that I've not had breast cancer myself, but I'm an Ashkenazi Jew and do have some family history of breast cancer, not a ton, but a little bit. And in my line of work, I decided about 4 years ago to go for genetic counseling and testing. And for me at that time, hearing all the pros and cons of panel testing versus just BRCA1 and BRCA2 testing, I ultimately decided to do just the full testing for those two genes as opposed to doing a larger panel, just because I felt those were by far the ones that I was the most at risk for, given my personal history. And I was sort of a little bit worried about knowing too much, that it might cause more anxiety for me. So I think it is, for some people more is more. For others, there's less is more. And for others, there's something in between. And I think really, sharing the pros and cons with our patients, and then kind of hearing them and sort of letting them sit with this a little bit themselves, and then guiding them to the right place is always the move that makes the most sense.
Thank you for sharing that too. And it is a personal decision. I know, having a mom with breast cancer, or a premenopausal breast cancer, she looked to me to say, well, what should she do? And so I think the nice part is that we do have a lot of motivators we have to put into the mix. And that goes really across the continuum, from our recently diagnosed to our survivors to our high-risk patients. And
Absolutely.
Would you like to add anything to that, Dr. Yepes?
So I have a slightly different perspective, in the sense that I am dealing usually with patients before we diagnose them. So what we're focusing on in the breast imaging part of the spectrum is really preventative, right? So we're looking at family histories of patients who have not yet had breast cancer and trying to decide who we should offer testing to. And so there we're really looking at family history and high risk factors. Usually the patient who has just been diagnosed with breast cancer, we know that they're going to be seen by the oncologist or the surgical oncologist or the geneticist. And so we leave that discussion to them. What we're seeing more of are patients who've been diagnosed with breast cancer in the past, who've kind of dropped off that specialized surveillance by the oncologist or the surgical oncologist. And we're being faced with, how do we continue to watch these patients in the future? How do we image them? And then picking up on whether we should at that point recommend that they go back and do testing. And sometimes they have already been offered BRCA1 and 2 in the past, many years ago, and then we're offering them the expanded panels based on their family histories and the fact that they tested negative many years ago. So it's a slightly different perspective.
But you bring up an excellent point, and I'll tell you, the last meeting that I went to before COVID hit was Miami Breast. And our poster, which was the saddest little poster in the world because I gave the wrong dimensions, it won Best in Show. And it was looking at our survivorship clinic, where we looked at over 1,800 women that were at least 10 years out. And we ended up, where we're a practice that I feel like we do a great job with testing. We still had another 220 women that qualified for either update testing or just hadn't been tested because of changing guidelines, or they were missed. And so that's another 13% of them that were positive. So you're bringing up a point that if we want to adequately manage our survivors, we do need to be incorporating in, not just in theory, did they get testing or did we review their personal family history? We also need to actually be testing them, because a lot of them didn't have that. So I think that regimented process, whether it's in an imaging facility, in a survivorship clinic, in the surgery clinic, wherever it is, we need to have that redundancy, because patients are being missed. So I appreciate that comment and think that it's obviously very important. So as we kind of take into our next, I'd like Dr. Meisel to kind of chime in on these NCCN guidelines, talking about some of the things we've highlighted, and then we'll jump into a case study.
Sure, absolutely. So I think, the NCCN guidelines are constantly changing, and I love that you access these this month, because I think, getting the most updated guidelines of who to think about testing in is very important. As you can see here, these guidelines encompass a lot of our breast cancer populations, patients who are diagnosed young, under 45 or under 50 with any kind of family history, or those under 60 with triple negative breast cancer, anyone with a history of Jewish blood or background, anyone with a family history of male breast cancer, and then ovarian cancer patients, pancreatic cancer patients, prostate cancer patients. And so, I think also people tend to think about, history of breast cancer, history of ovarian cancer, but they don't always think as much about prostate, pancreatic cancer, melanoma, things like that kind of falling into the mix, which they can with some of these breast cancer causing mutations. So I always feel like, whenever there's a family history of any kind, or a patient who's, young, it's important to at least refer them for genetic counseling and then let them decide, are they going to get the genetic testing or not? And I think this works differently in different practices. And for us at Emory, we are really lucky to have a wonderful team of genetic counselors who see our patients and do counseling now over Zoom, but it used to be in person, and then are able to help send the testing panel that makes the most sense. In other practices, I know this is done, in the oncologist's office or even sometimes in the breast surgeon's office. But as you said, I think having that redundancy that this, no matter how it gets done, it potentially needs to be done. And then I think the other thing I'll add, that's sort of that last tiny little bullet point there on the bottom, is that now we have different systemic therapy decisions that we can make for our patients with metastatic breast cancer that are ER positive, HER2 negative, or who are triple negative, incorporating PARP inhibitors. We'll talk a little bit about that in some of the case studies that follow, but this has also sort of expanded the option for genetic testing really for anybody with HER2 negative metastatic breast cancer, both because of course it can impact that patient's family members and what they choose to do about screening and sort of being proactive about their health, but also because now it can actually actively affect what we choose to treat these patients with, and how they do and their quality of life. So I'll stop there and we can move on to the next slide. Yes, so these are some estimates of annual incidence of hereditary cancers for some of the most common cancers that we have. So you see breast, ovary, uterus, colorectal, and prostate cancers, which are some of the most commonly inherited cancers with genetic mutations that we know of. And you can see that there's a very high incidence of patients with what we think to be hereditary breast cancer, 39,000 per year, roughly. And then you can see that that's about 12 to 14%. Some estimates would say a little bit lower, maybe 5 to 10%. But whatever it is, it's there. And as we learn more about different mutations, both different aspects of BRCA1 and BRCA2, and different mutations within those genes, but also things like PALB2 and others, I suspect that incidence will grow because some of these, potentially sporadic cancers or things that were defined as sporadic cancers years ago may just be cancers where we didn't really know what the hereditary factors were. So this is a number that potentially could grow as we learn more. So we can dive into a case. This will hopefully sort of bring it back to the clinic for those of you who spend time there. This is a case study of metastatic breast cancer. So a 62-year-old postmenopausal female who has a significant personal history of breast cancer. So in 1999, when she was 41 years old, she was diagnosed with a right breast invasive ductal carcinoma, grade 3. She underwent a lumpectomy and axillary lymph node dissection, which was the standard of care even for early cancers at that point. She underwent chemotherapy with AC ×4 and underwent radiation, all of this being standard of care in the late 90s. She then did fine for quite some time. And then about 16, 17 years later, she was diagnosed this time with a left breast invasive ductal carcinoma, so a second primary. This was grade 3. ER negative, PR negative, HER2 negative. And we don't know what the cancer was in 1999, but I think it's reasonable to assume that it was something similar. This patient, had already had adriamycin back in 1999, so she underwent neoadjuvant chemotherapy with TC this time, had a left breast mastectomy. She had a 2.1 centimeter tumor bed with a 1 centimeter sort of burden of residual disease that was about 20% cellular. And then she had no lymph node involvement, but 5 of the 5 nodes that were removed had evidence of treatment effect. So then she was followed and unfortunately was diagnosed in October of 2020 with metastatic triple negative breast cancer. She had an isolated lung lesion and underwent wedge resection for biopsy. So I can jump in and just talk a little bit about the genetic testing here. I think one of the challenges in this case, and this is not necessarily a real case, but a case that was designed for these purposes, is that there are patients like this, and we've probably all seen them in our practice, folks who come to us, for a new patient consultation, and we see a history like this and we wonder, how did this patient miss out on having genetic testing done before? You can see here, 6 to 10% of breast cancers that are diagnosed at stage 4. And of course, then these patients, come to mind when we think about genetic testing right away nowadays. But 20 to 30% of breast cancer will become metastatic. So I think, when we see these patients with early triple negative breast cancer, especially at a young age, it's still really, really, really important to think about genetic testing just so we can really understand, what is their risk going forward. And this is a very real case in the sense that this was a patient who, had her first cancer in 1999, thought she was done, and then had another triple negative breast cancer diagnosed 17 years later. And then now, of course, with metastatic disease at the age of 62. So this patient undergoes genetic testing now, certainly better late than never. And she's found to have a BRCA1 deletion and also an NBN mutation, both of which are classified as pathogenic.
And I'd like to stop and ask Dr. Chung to chime in too. When you see a report like this, obviously for this patient with metastatic breast cancer, the BRCA1 is the more maybe important of these two, but how do you put two pathogenic mutations into perspective for a patient? And would this potentially influence what Dr. Meisel would choose for treating such a patient with metastatic breast cancer?
Right. So I will say we don't have as much evidence as we would like. So I do think BRCA1 trumps, so to speak, the Nijmegen breakage syndrome variant that we see. It's not good to have two. In other words, I don't think it's going to improve the prognosis, and probably did contribute to the risk and the reason why she's had now 3 cancers. But in terms of the treatment decisions, I think most of us would probably go in part because we have more evidence for BRCA1 in terms of treatment. And again, because that's probably going to be the major contributing factor. We'll get into it later, but when we start doing cascade or talking about cascade testing, this does come up though, because these are 2 independent events. They're on 2 different chromosomes. And when you think about family members, you need to think about both of those for consideration.
I would just add before we get on into talking about PARP inhibitors that, had this patient been diagnosed with both of these mutations earlier on, I think it would have made us be even more inclined to recommend potentially that she undergo bilateral mastectomies, even at the time of the 1999 diagnosis, just because we know, and I think we've got a slide a little later on too, though, talking about how patients who have a genetic mutation like BRCA1 or others are very likely to have a second breast cancer if they've already had a first breast cancer. And, it's of course hard to know, and you don't want to be a Monday morning quarterback, but if this patient had had, definitive surgery back in 1999, maybe she wouldn't have had to experience the 2016 and then the 2020 diagnosis. And I definitely have seen patients in my clinics and counseled patients who have even BRCA1 or BRCA2 mutations who at a young age are just sort of shell shocked by the whole thing and have a hard time really wrapping their minds around, do I really need to think about surgery now or advanced screening? Can I just put this off? I'm so young. But certainly if someone had 2 mutations, that would make my, kind of pushing the doing something now conversation potentially even stronger. Now that this patient is metastatic, I think the BRCA1 mutation is the one that sort of more directly impacts what we choose for her treatment.
Absolutely. And I think you brought up that patient that kind of breaks your heart when you see them and it's sort of the coulda, woulda, shoulda, but the reality is, we have to deal with what walks in the door. But I think it's just reinforcing why that redundant sort of process is so important for us in identifying patients where genetic testing would be helpful.
Exactly. And I think when you experience that in the clinic, that's not something I ever would necessarily bring up to a patient, because I don't think there's any benefit for a patient to think about what they could have done in the past, because what's in the past is past and we have to deal with what's coming. But it definitely kind of, makes you think as the clinician, as I see patients going forward, what can I learn from this case that's in front of me? And I think, the thing I would take away from this new patient with metastatic breast cancer is, really, take those opportunities when you can to save people early on.
Absolutely.
I will say one little thing. I don't mean to interrupt, but
Yeah,
the particular type of mutation that she has in BRCA1 with the technology that we were using in 1999, even if she had had the testing at the time, it's very likely it wouldn't have been detected. So just people were talking about updates. It's another reason why we sometimes update what look like high-risk individuals, because the testing method improves.
Absolutely.
Yeah.
And update testing really, when we think about the cutoff, Dr. Chung, what date do you use for commercial labs? Like, there's sort of some variability out there, but if you see a patient tested before this date, you would do update testing. What's your sort of cutoff for that?
So personally for me, 2015 was a pivotal year in terms of things switching, both in terms of technologies, big data sets, in terms of being able to interpret variants and panels. So for me, that's a line in the sand.
Yeah. And so some
useful.
of the companies, like if they were tested through, there were fewer companies back then for testing as well. Some of them still do update testing at either low cost or no cost. So it is important to do update testing if patients had only single syndrome, especially if they meet some of that criteria that we've already heard today.
So it sounds like this patient would have been a good candidate for update testing in 2016, even if she had had testing back in 1999. Yeah, great. So PARP inhibitors, so this kind of jumps right into, what is different? What can we do for patients who have BRCA mutations in terms of treatment for their cancer? So this has been really a big breakthrough in terms of what we can do for patients. And PARP inhibitors are a class of drugs that really represent one of the earliest and first targeted therapies for what is mostly triple negative cancer. So PARP1 and PARP2 are enzymes involved in DNA repair, mostly involved in the repairing single strand DNA breaks. But if PARPs are inhibited, such as with a PARP inhibitor, and we'll talk about some of those drugs, then what those single strand breaks do is that they accumulate into double strand breaks. And we know that patients with BRCA1 and BRCA2 mutations have a hard time repairing double stranded DNA breaks. And so then this goes on to become a huge problem for them, leading to cell death. And so PARP inhibitors sort of help target just that, that Achilles heel that those BRCA1, BRCA2 cancer cells thrive off of, causing those cancers to die off. And this slide really kind of illustrates that very nicely, that PARP is activated by DNA damage, repairs single-stranded breaks, but if PARP inhibitors are present, those single-stranded breaks accumulate and then double-stranded breaks occur. And in a normal cell, you would have homologous recombination, the DNA would be repaired and the cell would survive. But in a BRCA mutated cell, those cells go on to die. And thus, if cancer cells are dying that way, that's a really useful way to do it. What's also really nice about PARP inhibitors is the ones that are on the market for breast cancer and for other cancers as well are oral agents that tend to be quite well tolerated. And we don't have slides in here about these two studies, but I did want to just briefly mention the pivotal studies, Olympiad and Embraca, which were two clinical trials presented at the ASCO annual meeting both several years ago, looking at olaparib and talazoparib. Olympiad was olaparib and Embraca was talazoparib. And both of these studies were for women with metastatic, either ER positive or triple negative breast cancer that had BRCA1 or BRCA2 germline mutations. And then these studies compared the PARP inhibitor, either olaparib or talazoparib, depending on which study you're looking at, to dealer's choice chemotherapy. And what they found was that progression-free survival was uniformly longer in the patients who received the PARP inhibitor. And on top of that, quality of life was better. And this was also interesting that in many patients in these studies, about a third, I think, in each trial, these patients had received chemotherapy in the curative setting, so upfront neoadjuvantly or adjuvantly, but had not had any treatment actually yet for metastatic disease. So in a patient like this who has newly diagnosed metastatic disease, and it sounds like not a large tumor burden, and had received chemotherapy prior, both in 1999 and again in 2016, I would absolutely think about starting her on a PARP inhibitor to treat her cancer now. And I think, this also gets into a little bit of, kind of COVID-19 and how it's changing our practice. But I think certainly still, down here in Georgia, COVID-19 is raging and a lot of patients really enjoy the option to take an oral therapy and come in a little less often, just having a little less exposure in this day and age. So the PARP inhibitors are a nice option for many reasons for these ladies.
Absolutely. And Dr. Chung, do you want to kind of go into what is that HRR and what are the genes, and could you potentially use a PARP inhibitor if it's a CHEK1 or other type of gene mutation as well?
Right. So one of the things is that diagnostics is often yoked to therapeutics, which makes a lot of sense, right? If this is news you can use, then you want to be able to test for the right thing. So the genetic testing has actually changed over time as the PARP inhibitors have become available. And some of these genes you recognize on this slide as being genes like BRCA1 and 2 that we've been talking about. But you'll also, if you're aficionado and do a lot of genetic testing, you'll notice that some of the genes that are on this particular slide are not ones that are commonly included within our panels. And that's because we do know the biology that they are genes that have to do with homologous recombination repair, but they're not necessarily genes that have been associated with hereditary cancers at this time. There's reason, again, based on the biology, to think they might be involved, but they're not commonly things tested. On the next slide, yep, thanks. So one of the other things we do, as we talked about, was tumor profiling. And sometimes what we can see is sort of the residual or the fingerprint of what was an HRR in terms of biology, but not necessarily mutations within those genes, but we can see the traces. And so there are particular profiles we see of the mutation profile, seeing that sometimes we lose one allele or one chromosome or one gene copy in the tumors, being able to see problems with the telomeres, for instance, but basically, as I said, a fingerprint that this is the biology of what's driving the cancer, and hopefully useful in terms of deciding a treatment course.
And I think the other thing I would like to ask Dr. Meisel too, is that you did a nice job kind of explaining why you may, because of COVID and choose an oral therapy, but would you always go to a PARP as the next choice because they have a BRCA1 mutation, or would you potentially look at other, like, how do you weigh that out and as you're thinking through that?
Sure. I think it's challenging, and we probably don't have time, nor is it really the scope of this talk, to get into, immunotherapy for triple negative metastatic breast cancer, and, looking at PD-L1 in these patients, which is also something we think about, because if these patients are PD-L1 positive by certain measures, then they also would potentially benefit from immunotherapy upfront. I won't discuss that right now because I think it's sort of out of the scope of this talk, but I would say, for these BRCA mutated patients, certainly we know the PARP inhibitors are going to be better in terms of progression-free survival and overall quality of life than dealer's choice chemotherapy, which includes capecitabine, both from the Embraca trial and the Olympiad trial. Capecitabine, which is really the only other good oral agent we have besides PARP inhibitors for metastatic breast cancer patients. That would be it. So for a triple negative BRCA mutated metastatic patient, I would probably think about reaching for a PARP inhibitor early if immunotherapy is not an option. And then thinking about, capecitabine and potentially other therapies down the line after that. For an ER positive metastatic patient, I think, these women probably are going to be a little bit more driven by their estrogen positivity as a whole than by their BRCA mutational status. So for most of these women, we would still be thinking about endocrine therapy plus a CDK4/6 inhibitor in the first line, and then depending on how long and how well they respond to that, potentially other endocrine therapies again before we would go on to PARP inhibitors. But having this, as an addition to our arsenal is really just a lovely thing. And then one really quick thing that I would add is that there was a trial presented at ASCO this past year, virtually, called olaparib expanded. It was a TRP-CBC, I believe, 48, that was looking at olaparib in patients with metastatic breast cancer who had somatic BRCA mutations as well as other germline mutations, and saw a really nice signal in the somatic BRCA mutations and in germline PALB2 mutations for responsiveness to PARP inhibitors. So I think this may be a class of drugs that gets expanded to folks with other genetic and genomic mutations in the future.
So we love the word choice because it does give you choices, and
yes,
and nice for these patients and unique to breast. I mean, breast has a lot more lines, I think, as we look than other disease states, but this is really, I think, a great example of how germline and or somatic testing can really influence some of those treatment choices. So
absolutely.
kind of reinforcing that. And I'll let you kind of take it into the next case study as well.
Sure, absolutely. So this next study, this is an earlier stage case, a 41-year-old premenopausal woman. She undergoes a mammogram, which is abnormal, and she's noted to have 12 millimeters of calcifications in her right breast. There's a mass and then some segmental distribution of calcifications sort of surrounding that. She has a biopsy. It's positive for invasive ductal carcinoma. Unlike the other patient who was triple negative, this is an ER/PR positive patient. She's HER2 negative, grade 2, and she's stage 2, a T3 and 0. She undergoes neoadjuvant AC, probably because of her age and the size. She undergoes paclitaxel 11 weeks out of a planned 12 weeks, stops a week early because of severe neuropathy. She is going to undergo surgery, a radiation consult, and is planned for endocrine therapy once radiation is complete. Going on to her family history, she has no known Jewish ancestry. Her mother, though, was diagnosed with invasive breast cancer at the age of 53, so kind of perimenopausal. She has a grandmother on her dad's side who had invasive breast cancer at the age of 85, and an aunt with invasive breast cancer at the age of 75. The patient has 2 daughters who are 9 and 11 years old. And she undergoes genetic testing and is found to have a mutation in the ATM gene.
So I think the first question that we would ask here is, how does an ATM gene mutation, based on kind of the medical management and that we see here, and this is from the most recent NCCN guideline as well, how would that, or would it influence any of your decision making in regards to surgical management or treatment options?
Yeah, so I mean, I think it's a little bit difficult. It's not a BRCA1 or a BRCA2 mutation, but we know that patients with ATM genes, as you see here, do have an increased risk of breast cancer. And importantly, this patient has already sort of shown you that, and that she's 41 and she has already been diagnosed with breast cancer. She also has a strong family history, you know, a little bit of a history on her mom's side and also a history on her dad's side. And so as with all genetic mutations, you know, we think about penetrance, and it seems like, you know, potentially this gene is relatively penetrant in her family. And so I think, you know, at 41 with a breast cancer for which she'll already need some kind of surgery, she's someone who I would probably encourage to think about, you know, whether bilateral mastectomies make sense for her at this time. Just because I think, you know, it would be something I would personally consider. And I think I always try to put that, you know, put that personal spin on things. You know, why might you think about this? Why might you not? I think, you know, as you can see here, these patients are certainly recommended for enhanced screening if they don't choose to have definitive surgery in the form of mastectomies. So she would be, if she chose to do breast conservation, if she could with a T3 tumor, that would be a discussion with the surgeon. But if she could do that, she would also, you know, have to think about how she would feel about, you know, mammograms, breast MRIs, the potential callbacks and future biopsies, you know, what that would be like for her, both logistically and, you know, psychologically. And so I think a lot of people would choose to have bilateral mastectomies in this specific situation. And then in terms of other cancer risks, there's potentially an increased risk in ovarian cancer for these patients as well. She doesn't have a family history of this, but with an ER positive breast cancer, you know, we would be probably recommending ovarian suppression for her anyway for treatment of her breast cancer. So she might be someone for whom you would also have kind of a, you know, a discussion about possibly doing a risk reducing salpingo ovarectomy. Again, you know, very much thinking about, you know, shared decision making and what does she fear about that, if anything, and you know, what the pluses and minuses might be for her. But I think a lot to talk about here with this poor lady.
This is a longer discussion, and
Yes.
we will get into that enhanced screening here in a few. But I would like to talk a little bit about the fact that, you know, as you said, you know, it's the risk for the primary breast cancer with an ATM, but we don't have that data outside of BRCA1 and 2. And Dr. Chung, do you know, what's the landscape of when you think we'll have some more of that type of information to predict like second primary cancers and some of these moderate gene carriers?
So people may have heard about some very, very large population-based studies. UK Biobank is one of them. All of Us in the United States is one. I think these are going to help us to identify more mutation carriers and also give us probably less biased estimates in terms of both risk of cancer in the first place and then risk of second cancers. But it's complicated. It's also, there are other dimensions. And I think, as Jane was saying, the fact that she's declared herself already at such a young age of having cancer, there's something else that we're probably not detecting on this genetic test that's increasing her risk. And so just realize ATM is probably not all of the story.
Right. And I think that's important, as Dr. Meisel said, that we have this long discussion we're going to have with this young patient who has young children. This is not just, here's what the evidence tells you. This is where the art of science and the science of science sort of merge together. And, you know, there's not a perfect answer to that question, but there is that sort of human experience. And I like the fact that, you know, both of those descriptions that you guys just gave really highlight the importance of why we do share decision making, because it's not, you know, a black and white answer. There's a lot of gray, and that gray is not always supported by evidence. Anything else you guys would like to bring up about kind of that discussion, especially in regards to treatment decisions? You know, we've talked about, you know, there's the rare mutations that can be impacted and a risk increased with radiation therapy. Would that come into your discussion? You know, how would you bring in some of those nuances, or would you just start with the bilateral mastectomy discussion and then go from there?
It's tough, and it's tough that this patient, you know, the question stem was T3, because some radiation, and others can speak to this as well, but you know, it's not as clear cut whether T3 patients can get away without post mastectomy radiation, you know, as she would if she were a stage 1. So I think, you know, I would probably have in real life have this patient see a radiation oncologist to discuss in depth the recommendations for radiation therapy, but I would have an in-depth discussion with her about the bilateral mastectomies just because of her young age, the fact that she, you know, has already developed a cancer, her family history, and this mutation. You know, I think in the real world too, what I see a lot in my practice is that young women, even without genetic mutations, if they're diagnosed with breast cancer in their 30s and 40s, are often choosing bilateral mastectomy for right or wrong, but just because there's so much, I think, post-traumatic stress associated with going back for those mammograms, that for a lot of women, you know, looking at, you know, a 30-year future of potentially having callbacks or maybe a second primary is enough for them to want to make that decision. So I think this would be someone for whom I would certainly have that initial conversation about the bilateral mastectomies right away.
And Dr. Yepes, I think this is a good segue to asking you, that post-traumatic description that we just heard, how do you guys address that? What are your thoughts on that?
Well, when we see these patients before they elect their definitive surgical treatment, we talk about that. And we tell them that this is what they're up against and that there's a high probability that they're going to be called back with some consistency for biopsies and additional workups. And let them know that we'll do our best to follow them, but that there's nothing 100%. And that's where they have to make that personal decision of how much they're willing to put out there, put themselves on the line versus going for that bilateral mastectomy. It's a very difficult decision for many of them. And we oftentimes see our surgeons also holding back on the bilateral mastectomies. And so it becomes complicated sometimes.
Mm-hmm. I like the way you described the normalization of that, though, because we need to normalize it from, once again, sort of multiple vantage points. And, sometimes we refer to things as the frequent, like on the backside, as the frequent flyer program. But the reality is we need to normalize that for the patient, because that is something that some of them, sometimes you don't hear it the first time you hear it. So it does need that repeated message that the patient's prepared for that. And Dr. Meisel, were you going to?
I was just going to say, yes, along the lines of kind of the shared decision making, because these are not easy decisions, and most patients, until they're diagnosed with cancer at a young age, have never thought about this stuff. Whereas, in our field, we spend a lot of time thinking about this stuff. I always encourage them to, really think about what worries them about all the different options. If they're inclined towards one thing, why is that? Really to kind of pick out those pieces, and then also really to seek out as much information as possible. So kind of making proactive referrals to, breast surgeons, plastic surgeons. They can learn more about what the reconstruction piece would look like if that's a concern. I think for many women in this situation, getting as much information as possible about, what things would look like if they choose either option is very, very helpful. And, pros and cons. You don't want to overthink it, but you want to make sure that you've gotten enough information to make the right choice for yourself and not regret it when you look back. And I think, that's a big thing. And I see that particularly for patients like this one, young mothers, you don't want to look back and have regrets.
Absolutely.
One other thing I'd like to add there from the imaging point of view is that not all breasts are the same imaging wise either. So some breasts are very easy to image. You have a fatty breast that has a very silent MRI where you're going to find something very easily. And some patients just have very, very difficult, busy breasts with a lot of findings where we know we're going to have a very hard time. And those are the patients that we will often try to push and tell them we're going to have a hard time following you. And sometimes that can help them make that decision.
Those are great points. And I think that definitely goes into that need to have sort of that shared decision-making discussion, have the time to do that. And then obviously this will impact her children who are young. They're still, sort of preteens, and we'll get a little bit more into cascade testing, but this has a bigger implication for not only this patient and her treatment plan, but also for her children. So I wanted to dive a little bit into this because this sort of teed up why we asked that question when we started this discussion, should we be testing everyone? And that lends to the American Society of Breast Surgeons, who last year came out with a position statement saying every patient should be made available the option for with a personal history of breast cancer of genetic testing. And how do we kind of feel about this? Because the estimates that we talked about that Dr. Meisel went over, showing what proportion of patients every year may be attributed to hereditary breast cancer, that was based on NCCN guidelines. Whereas if we're now going to be testing every patient, first off, can we handle that? Is there a pro and a con to that? And I just wanted to throw that out and get anyone's opinions kind of on these professional positions. Or not, you don't have to, but
I think these are tough questions because I think, there are a couple of sort of logistical things, wanting to make sure patients who are getting testing are adequately counseled, both pre-test and post-test, wanting to make sure that we are, thinking about the insurance coverage and the cost piece too, because just because we say it should be offered and should be available doesn't mean that it necessarily is. And for many patients, especially in these crazy financial times, the cost of such testing, if their insurance is not covering it, could be prohibitive. So I think we do have some logistics to think about if we were to sort of make this just available to everyone. But I think the counseling piece is really the big part, because you want to make sure that you're, able, especially if you're thinking about panel testing for like broad numbers of breast cancer patients without any family history and who may have, postmenopausal stage 1 tumor. You just want to think about how you're going to counsel these patients and, the risk of variants of uncertain significance and all these things. So I still feel like, the option for counseling should be made available to all, and then people can decide on the testing. And then I guess the question of, do we have enough genetic counselors to sort of meet that need if patients desire that. I will say there are a lot of patients who I do talk to about genetic testing if they're the only person in their family who has had an early stage breast cancer, postmenopausal. Many times they opt out, and I think that's reasonable in some of those situations. So I don't necessarily think everybody is going to want this, nor maybe needs it.
Yeah.
So I'll just throw out a radical idea on this. So just to show a pro or a versus the con. So one of the things I think is in terms of systems of care, things can fall through the cracks. And so there's some certain simplicity that if you just say everyone, then you don't have to overthink it. You can just have it as part of a system of care in terms of doing things. And again, if someone has the choice to opt out, I sort of think of this as an education to start with, be educated about what your opportunities are. And then, as we've been talking about, let everyone make a decision for themselves. And hopefully we're developing scalable ways of education in terms of, this is something that I think a lot more women are aware of and have heard about, even perhaps have friends or family who have gone through this. And so hopefully we'll reduce the barriers. And I do think that's one of the things is with very complicated care, seeing multiple specialists, one of the things I hear a lot is, from point of care testing, so to speak, not that we're actually doing the testing at that point, but it's incorporated into those, sort of evaluation very quickly, and especially for those women who want to make surgical decisions based on that, really being able to get the information quickly so that they don't have to make multiple decisions. It's one decision based on comprehensive information.
Absolutely. And as we think about it, you guys brought up some great points already. Do we have the capacity? Does every patient need testing? And, I think COVID's really transitioned people who weren't doing telehealth to genetic counseling. Is pretty much all telehealth right now. I switched my practice about 5 years ago to only telehealth for genetics. And I find it to be, very accessible, very doable. But I also think that, as we think about it, we still, don't have enough genetic counselors. And how do we use our geneticists and our genetic counselors and our genetic experts? And then how do we bring it, like Dr. Chung said, into the clinic? So I think we still have some logistical barriers to sort of work through. This was presented also at San Antonio this year by Dr. Robson, and I thought it was interesting. And I just wanted to point out that, as he highlighted this data, and Dr. Chung and Dr. Meisel and Dr. Yeppe said, like, your opinions too, they sort of talked about if you took all comers and sort of threw them in and tested them all versus if you risk stratified by age, how many would you really miss? And if you look at this group here, which this is the one like the over 70 or over 75 with breast cancer, you're only missing 3 to 5% of those potentially with the gene mutation. So is there a way that we use age as one of those criteria? How would you age plus maybe family history, or how do we feel about sort of missing a few, and or do we just want to go to that system approach that Dr. Chung highlighted? And I don't think there's a right answer. I'm not asking for a right answer. I just thought this was an interesting way to sort of think about it and really narrowing down how many would we miss if we just sort of looked at age.
Well, I think the other thing that's tough and that's always interesting to me to think about, when you see a patient who's very, very elderly and has been diagnosed with breast cancer is, identifying a BRCA mutation. If you're 85 and you've got an ER positive breast cancer and you have a mutation, how much is knowing about that going to change what you do or change your lifespan? I think it is a lot different when you're under 50. So I think, it sort of depends. Like if you're testing 175-year-olds and you're going to find 2 of them, and how much are you really impacting those 2 patients' length of life, quality of life, et cetera? I mean, I think the cascade testing piece is a big chunk of that because, if you've identified that woman, but then she also has a 40-year-old daughter and, 10-year-old granddaughters, then potentially you've saved some lives. So I think there are 2 arguments there.
And the argument from the insurance company, because I sat on a CMS panel when they were doing the NGS sort of what should we approve and what we shouldn't, their pushback was, well, we don't care about that cascade testing. We care about the patient sitting in front of you, which breaks my heart and breaks your heart. But that I get that from a Medicare standpoint. They care about the person sitting in front of you, not the daughter or the sister or whomever. So I think that we are definitely influenced more by that bigger picture than just, you know, the treatment plan for the patient. But I like your sort of thought process. And Dr. Chung, were you going to comment about something on that too?
Well, I was just going to say that 70 is the new 60, and you know, so you know, we're living longer and hopefully healthier lives, and so you know, there's still chances for second cancers. You know, an ovarian cancer after a breast cancer for a BRCA1 or 2 carrier. And I'll also say, in terms of the cost of testing, the cost of testing really has come down really significantly. And so even if Medicare isn't covering it, if it's $250 out of pocket, I realize not every patient can afford that, but there are certain patients who would say, yeah, I mean, that's for peace of mind, or for my family's peace of mind, it's worthwhile.
I agree.
And in those cases, I sometimes throw in like, well, why don't you have your children pay for it? You know, if the patient herself can't, because they're the ones who are really going to benefit from the information.
Absolutely. And it's sort of one of those gifts that keeps on giving, right? Like when you think about the cost of genetic testing, which is actually one of the most cost-effective tests that we have, you know, the family paying for that $249 test is money well spent for grandma's Christmas present. And I've actually used that as an example for patients who are like, oh, we didn't know what to get grandma. So this is fabulous. So, I mean, we know that sounds a little hokey, but when it comes from your medical provider, you know, that is a gift that keeps on giving. So anyway, I appreciate that discussion. And let's dive a little bit into cascade testing based on this patient and others. And Dr. Chung, do you want to kind of review this for us a little bit?
So I didn't say it earlier, but the genes we've been talking about are what we call autosomal dominantly inherited, meaning you've got 2 copies of the gene, and most of these are inherited. So that means it's likely it came from either the mother or the father, and if you have children, there's a 50-50 chance of transmitting or passing down. So the idea is just like a pool, you know, you throw a stone into the water, it cascades out or ripples out is what I say, so that you can look at all the first-degree relatives, meaning moms, dads, brothers, sisters, and children, and then based on who's positive, cascade from that person, and then really fill out the family. And so that target, and let me be very clear, the testing that gets done in a cascade sort of way is very targeted. It's just looking for that one mutation that's been identified in the family.
And that was also discussed at San Antonio about the cost effectiveness of the cascade model, and how if we were more effectively testing those probands and using cascade testing, that leads into kind of our next slide, that's sort of another cost-effective method. How do you feel about that?
Yeah, so depending on how many people you test, and that the curve on the right is just a fancy way of saying that if you do first-degree relatives only, or go to first or second or third-degree relatives, but the farther out you go, the quicker, the faster you could get to saturation in the population of identifying all the mutation carriers out there. So I think of it in some ways in COVID like herd immunity we're doing with vaccines. In the same way, it's kind of figuring out for population health how to be able to identify everyone at risk. And I'll just very briefly say some of the genes, though, are dominant for the cancer, but they're recessive for reproductive purposes. And so some of the things in terms of ATM or Nijmegen breakage syndrome, for those that have a younger generation that are having kids, again, if it's 2 mutations, it's a much different condition. Oftentimes, I think of as much more severe. So it can be helpful for reproductive purposes aside from the cancer as well.
And we discussed this slide earlier. This is a scary looking slide, but I could not find a good replacement. So we'll just dive into it and then move on quickly. So
this is just to say that although you might come in the breast cancer door, you might end up finding that you're going out another cancer door in terms of an associated cancer. And so this is really to make sure people don't get blindsided by something that wasn't on their radar because it wasn't in their family history or personal history, but is associated with the gene that got them into the breast cancer door.
So really establishing those expectations up front.
And I will say just very briefly, you may have seen on that last slide was prostate cancer. And just to remember, these genes matter for men as well. Just because men don't usually get breast cancer, they can get prostate cancer, pancreatic cancer, melanomas, some of these other things. So when you think about cascade testing, it's men and women for the cascade testing.
Absolutely.
And that's the part that's a little difficult for my patients to understand when they come into imaging and we ask them about their paternal family history. They find that hard to grasp. So that's a very important thing to take into consideration. So very quickly, just to go over the imaging guidelines for these high-risk patients. So the American Cancer Society and NCCN guidelines came out a while back, saying that anyone who has a 20% or greater lifetime risk of having breast cancer should be screened with annual mammograms and annual breast MRIs. Now, a very important fact here is that adding ultrasound to that mix has been found to not increase cancer detection. And on the other hand, it has caused increased false positive biopsies. So adding the ultrasound to that mix actually has a deleterious effect. There is some evidence for staggering the mammograms and MRIs. The first studies done for high-risk patients were all done simultaneously, but there has been some minimal recent evidence that it might be a good idea to do them every 6 months. Next slide, please. So these are the results from that AVA trial looking at the cancer detection yield depending upon modality. So we see 5.4 per 1,000 with a mammogram, 6 per 1,000 with ultrasound, 7.7 when you mix mammogram and ultrasound. And look what happens when we add MRI. So a much higher cancer detection yield with MRI. And here we see how the best possible combination is MRI plus mammography. Ultrasound adds no further cancer detection. Okay, and this AVA trial, half of those patients had been done at different times. So they were not simultaneous, which again, proves the fact that adding ultrasound to the mix is not helpful. Next slide, please. So the emphasis is on trying to find the biologically relevant cancers. And this is why vascular-based screening is important. Adding contrast to our imaging is what helps us find that the very aggressive cancers, whereas mammography and ultrasound look more at morphology more than behavior. And this is why we recommend that MRI. So there is some growing evidence that contrast-enhanced mammography can be a good addition to the MRI instead of a routine mammogram. And so in this way, we would be doing contrast-enhanced imaging every 6 months. So doing an MRI in January and doing your contrast-enhanced mammogram in July. Again, just growing evidence, still not standard of care. But what is important is that contrast-enhanced mammography can be a good alternative for those patients who have contraindications for MRI, either because they're allergic to the gadolinium or because they're extremely claustrophobic or have implants that are not compatible with MR. Next slide, please. So this is just from one of the studies that showed the importance in the different behavior of the cancers, the different aggressiveness according and how those different aggressive cancers are detected with MRI versus mammography. So we see that the low-grade DCISs are better seen on mammography than on MRI, whereas when we go to the higher grade invasive cancers, MRI is where we're going to see them best compared to mammography. Okay, next slide, please. And so the question is, when do we begin? When do we begin this aggressive screening? And so it depends upon that mutation. As Dr. Chung said, there's the papa bears and the baby bears, right? So I kind of lined them up according to aggressiveness and how early we should begin screening. So the TP53 should begin at the earliest age with MRI between the ages of 20 to 29, and then beginning with mammogram at age 30. So interestingly, these guidelines all go up to 75. But again, as we mentioned, 70s are the old 60s. And so this is where we need to take into consideration this patient's quality of life and her life expectancy. The BRCAs and the STK11 should begin with MRI at 25. So from 25 to 29, just MRI, and then add on the mammogram at 30. And with the same with the PALB2, we begin at 30 with both. And finally, the CHEK2 and ATM, which are lower penetrance, we can begin with both mammogram and MRI at 40. So earliest with the TP53, latest with the CHEK2 and ATM. Next
Great.
slide, please.
Yep.
And just a very, very quick case study. So this is a 58-year-old female with a BRCA2 pathogenic variant and a history of ovarian cancer who has been doing breast cancer screening. So this was her MRI, which showed this unique focus in the medial right breast up here. Very bright focus. You see how it's red on the color maps, which means that it has aggressive type of vascular activity. And if you put up the next slide, please. So this is her mammogram. So you see, I don't know if you don't see my cursor, right?
No, we can't see you. You want me to move it for you? Right here?
Yeah, so if you see, right, so come down a little more towards the bottom of the slide. So like, and towards the skin, right, exactly there, just a little higher. That would be where that bright focus that we see on the MRI should be. And that's a fatty replaced area. So this brings home the point that MRI is helpful no matter what the breast looks like in terms of density. It's going to find those extra cancers, whether the breast is fatty or dense. So some people believe that if you have a fatty breast and you have a BRCA mutation, you only need to have an ultrasound in addition to the mammogram, and that's not true. You have to have an MRI. So it's independent of that breast density. Next slide, please. And the other thing is that we have to have a much lower threshold for performing biopsies. So that focus that I showed you on the MRI, it looks very benign. And in a patient who does not have a mutation, we would probably just do a follow-up because it had relatively benign characteristics, aside from the vascular appearance. But in patients who have these mutations, our threshold has to be much lower, and we have to biopsy anything that's new, even if it looks benign. And that's why they're up against that many biopsies if they decide to keep their breasts.
So we also included, I included this table just because Dr. Ford had shared this with me, and I keep this as my own little cheat sheet and I update it kind of as needed. So I have all my kind of tricks to the trade. So I would recommend that if you don't have a little tool like this, use one, borrow one, modify one, because it does help. And Dr. Chung, do you use something like this, or is my little tool that I borrowed pretty basic?
No, it's great. And as you can see from that second column in terms of relative risk, we've been saying this, but it's easy to get the alphabet soup jumbled in your head. So it's great to have it to refer to. And just before you walk in to see the patient, you can check your chart and look like you're a rocket scientist, a geneticist, and that knows all of this off the back of their hand.
I am not, but I have lots of colleagues that depend on me to keep them up to date. So I try to develop little workarounds. So
always good to walk in there looking like a rocket scientist,
Yeah, great. So as we kind of finish up, we've covered a lot, and I can tell you that I've enjoyed listening to this panel. You guys are amazing and articulate, and really had a great way of instilling discussion. So as we kind of summarize tonight and we kind of leave with our next step, what would your take home be for folks listening, participants, sort of the take home of genetics and genomics in 2021? And any of you can start, whoever would like.
I would just say you've gotten up to date for about 5 minutes. So that this is continuing to change, and just keep up to date and keep listening to things like this. And we'll try and make it as accessible as possible by keeping to make these cheat sheets or act sheets or other things that'll help you guide you along the way.
I think one other take home is just that knowledge is power. We now know more and more about what to do with these different genetic mutations, how they can impact patients, risk reducing decision making, as well as, the treatment of actual cancers. And so this information and, considering getting genetic information on patients will become more and more important as time goes on, for breast cancer patients and for patients with other cancers as well. So continuing to partner with our, genetics teams, but as you've seen even here tonight, how important it is to talk with radiologists about, what are these patients' breasts really look like, what is the risk of an additional cancer for this woman, and really kind of gathering all the information you can to help your patients, make the best decisions for themselves personally.
And as from my point of view, from the radiologist looking at the preventive side of it, I guess my take would be, let's help these patients really understand their family history so that when they come for their mammograms and their breast imaging, we can direct them and do what's best for them in terms of enhanced screening when they need it.
Absolutely. And I think we've heard the fluidity of genetics, the shared decision-making, the treatment influences, the prevention that comes along with it. So this really is a comprehensive tool that needs to be sharpened on a regular basis in our toolbox. So as we kind of summarize for today, we want to thank you all for your time. We want to thank the organizers, thank our panel for their time, and we wish that you will stay healthy and happy into 2021. We are now heading into a break, so please use this time to earn some points from our Engage and Win giveaways by engaging with exhibitors in the exhibit hall and networking with your peers in the network lounge. So thank you all again, and we will hopefully see you next year and maybe in person. Stay well.